I would like to introduce you to Dr. Tracy Ridley. Dr. Tracy Ridley has been a physician at Winnipeg Children's Emergency since 1998. She also goes to Thompson to do pediatric locum work. She's a medical graduate from the University of Alberta and did an internship at the Royal Alexandra Hospital in Edmonton. She did her pediatric training at the University of Manitoba. She practiced in Terrace, BC for 2 years prior to coming back to Manitoba. She's currently on the emergency patient care team and on the competency committee for the Pediatric Emergency Medicine Fellows. When not working, she enjoys spending time with her family, loves photography, and always looks forward to getting back out to the Okanagan. And now over to you, Dr. Ridley.
So I chose to start doing the talk on bronchiolitis. So I remember very early in my career going back and looking at what books in the 1970s were talking about for treatment of bronchiolitis and see how it's changed. And I was amazed how it hasn't changed that much, and they keep on trying to find a way to help these kids and going over the same stuff, trying to tweak it to find a magic cure. In the end, there is no cure, but there are things that we can do to help. So objectives, what we're going to do is we'll talk about obviously bronchiolitis and look at what investigations can be helpful, the management of it, both before being admitted to hospital and in hospital, and talk a little bit about asthma versus bronchiolitis and our plug on immunizations for this to try and prevent it in the first place. So first case, so 6-month-old boy, he's got a runny nose that started about 4 days ago. Now his chest is noisy. He's drinking well, but warm to touch, and he's also avoiding well. So by history, he seems to be well hydrated, but concerned about his breathing. So when you go in and see him, he's happy, he's well hydrated, respiratory rate is up at 50, his SATs are 92% on room air when awake. But you can obviously hear the wheezing. You don't even need the stethoscope, and he's slightly indrawing, but again, happy and doesn't seem to be in distress. So in the emergency department, we just suction out his nose, give some normal saline drops for his nose, and advice on suctioning at home. And we discussed what bronchiolitis is and discussed when to come back, but sent home despite being nice and noisy, but he otherwise looked well. Now, a different case. It was called by the grandmother, who is a physician. So family came to visit for the holiday, so it was right before Christmas. 3-week-old granddaughter is having a hard time breathing. Noted periods of pauses of breathing, and they're coming to the hospital. So the grandmother wanted to warn us that this kid was coming. I must admit, I did question her, so you called the ambulance, and they unfortunately made the decision that it would be faster to drive on winter roads, faster to drive to come to the hospital that way than waiting for the ambulance to bring them in. Forgetting that the ambulance comes with help and ways to alleviate problems. The reason it was bad was because the baby presents in emergency department triage in a car seat. The color is gray, the kid's apneic. Thankfully responds to stimulation and immediately given O2. Did give an epi mask and the kid does come around. Managed to stabilize the kid and admitted to the ward on monitors. And yes, I did tell them that next time, call the ambulance, because all they had to do was get stuck on the road, and that 15, 20 minutes extra would have been a totally different outcome for this kid. So, definition. Bronchiolitis, it's a lower respiratory tract infection. It's obstruction of the small airways. It's acute inflammation and edema and necrosis of the epithelial cells. And you get the increased mucus production, making it obviously very difficult to treat. These are the most common viruses. RSV, obviously, the 80%, I believe, will be caused by RSV results in bronchiolitis. Human metapneumovirus, influenza, rhinovirus, adenovirus. Adenovirus is really nasty because adenovirus will often end up with ongoing chronic lung disease, unfortunately. Parainfluenza, coronavirus, and yeah, that does include COVID. Worst part is you can get more than one virus. They used to try and do a rapid RSV. Now we have more rapid with RSV, influenza, and COVID. And they tried to cohort these kids. And what they ended up doing is they would get the more spectrum of the viruses, and these kids were cohorted with RSV, but unfortunately, they also had other viruses which they spread each other around. So that was not a good decision. So now these kids all get isolated. So when starts usually around November to January, and the usually season lasts about 4 to 5 months. And yes, it's really fun when influenza and RSV are peaking together because it makes any emergency room just busting. It makes the kids quite ill. So, how to diagnose? Big thing is it is done clinically, and you don't need a sick contact. Many families will often say, "So, how did this kid get it?" And it's so hard to get them to understand that RSV, especially, is out there, easily transmissible, lasts on surfaces for a long time, and the caregivers aren't necessarily sick at all with it. So, easily can be passed on. So typical course is less than 12 months old, mild cold and runny nose for about 2 to 3 days. And then they start getting fast breathing, and then they start hearing wheezing and the crackles. Usually worse by day 5 to day 7. It's usually peaking then for how bad it's going to get. And then they can, unfortunately for some of the kids, they can develop severe respiratory distress, but anywhere in long, it isn't necessarily day 5 to day 7. But they get grunting, nasal flaring, indrawing and retractions, abdominal breathing, you notice, color change, low O2 sats, and worst of all is the apnea. So ones that we worry about that are higher risk to get into more problems. So kids under 3 months old, especially under a month old, because they can actually just show up with apnea, or less than, when you think about the premature kids, less than 48 weeks corrected age. With the You also can notice the ones that come in that are cyanotic or presenting with apneic spells, kids that have cardiopulmonary disease, so any chronic lung disease, especially from prematurity, or congenital heart disease. If they have an immune deficiency, anything also that they can't clear their airways well. So if you think of a neurological difficulty, that they can't cough up their secretions, they have a structural lesion, anything that's going to cause them to not clear their secretions. So things that are differential, usually the top one, of course, is asthma. I also can think of other pulmonary infections, laryngotracheal malacia, foreign body aspiration, especially if you think about those kids that are on the move and can easily get something and then choke on it. GERD, congestive heart failure, vascular ring, allergic reaction, and yes, little ones can have bad allergic reactions. Cystic fibrosis, mediastinal mass, tracheoesophageal fistula. Those would be the major ones. So labs and radiology. Essentially, don't use them to make the diagnosis. Again, the diagnosis is made clinically. We're using labs and the radiology to help us decide if the story isn't correct, we're concerned. That's when we use labs and radiology to help us out. Chest x-ray never should be routine. If I always like to say, walks like a duck, talks like a duck, it's probably a duck. So you don't need a chest x-ray. It doesn't help you in making the diagnosis. And they've shown that by doing x-rays on these kids, they end up receiving antibiotics unnecessarily. So consider if the diagnosis is unclear, there's severe respiratory distress, and what you're actually looking is not for bronchiolitis, you're actually looking for complications. If their condition deteriorates, and again, looking for those complications if you're concerned about it. NPA, not routine. What it does help is, again, sometimes help with cohorting, but you have to make sure that they don't have any of the viruses so that they're only tossing back and forth the same one. If admitted, an influenza A, possibly Tamiflu may be helpful, but usually by the time that they come into hospital, they've already been symptomatic, and Tamiflu will probably be of little help. CBC. Just because your white count is elevated doesn't mean it is definitely a bacterial illness. It's not, because it's stressful when they're sick, so it may just be elevated from that. Just because your CBC is normal doesn't mean that it rules out bacterial illness. Consider a CRP, but again, CRP is a guideline. It's just one of the factors, and really you're looking at the kid to help out what is going to be best for the kid. And when it comes to the guidelines for fever and what to do, especially in the younger infants under 60 days, that's a whole other talk, but just follow the guidelines on that. So when to admit, what you want to be looking at is respiratory concerns, hydration, and parents' ability to cope. Some parents really just are uncomfortable dealing with this. And those are the ones that come back literally 2 or 3 times in not as many days. You will see them a couple of times a day and you realize they just aren't coping. Sometimes you get away with just holding them overnight, just showing that we don't have to do anything else, but it does become difficult for them. So management. Essentially, we're going to go over the CPS guidelines. And I'll talk a little bit about difference between the American. So beyond wiping that nose, there are only 2 things that are unequivocally proven to help, and that's oxygen and hydration. And we'll talk a little bit about the other stuff. So suctioning. Be gentle, keep it nasal. Deep suctioning, actually, if you keep on going back with the deep suction, it may prolong the stage just because of the irritation. So wall suction with your nasal suction on it, or the bulb. I just showed a picture of one of the ones where essentially the parent or caregiver becomes the wall suction while you put the other end into the baby's nose, and that really helps with suctioning compared to the regular bulbs. Using normal saline drops, again, just to move around the secretions, wet them up so you can suck it out better. And it may be helpful if you do it right before feed so they can get a good feed in. Let's talk about epinephrine. So dosages by mask are 10 milligrams. So it's less than 10 kilograms. It's 3 milligrams of 1 in 1,000 in the mask. You can fill it up to 5 ml, so adding another 2 mils. Or for greater than 10 kilograms, it's 5 milligrams of 1 in 1,000. And this is where I say may help. Make sure you're checking if it helps. Don't just give it and just assume that it's helping. And even if it helped once, it may not help the next time. So the hardest thing you can do is, because you just want to help these kids, is you keep on giving epinephrine to try and make their distress go away. And always remember that when you're given epinephrine, it's not going to take away their wheezing. What you're trying to do is help with their work of breathing. The wheezing is going to be there until their illness improves. So this is what we use at HSC, is the bronchiolitis clinical scoring tool. And it goes through to try and make it more objective to categorize each one. So the general appearance, your respiratory rate, your retractions, the breath sound intensity, your adventitious sounds. You get your total score. You give the epinephrine, and under anywhere from 30 to 60 minutes, you do the score again, and to see if it actually makes a difference. And it's to try and more make it objective to see if you've actually made a difference with the epi mask, instead of just saying, because we'll always are going to have a bias that because we go in and do something, we think we're making a difference. And that isn't always true, especially when it comes to medication for bronchiolitis. And that's just the back of the sheet. So now the question, epinephrine and dexamethasone. Really, the research is on the fence about this. Some studies say that, oh, it has made a difference. Other studies haven't. I remember reading one study where they talked about giving 0.6 milligrams of dexamethasone a few days in a row. And it said, oh, this made a difference. And Probably what they did was made sure this kid didn't have any fever with the amount of dexamethasone they gave. And again, it hasn't been able to be repeated. It's just so hard. It just everyone keeps on wanting to try and find something that's going to help these kids. Hypertonic saline. The hypothesis with this is that it increases mucociliary clearance and rehydrates airway surface fluid. So like you go around the countries that have difficulty with bronchiolitis, they'll have a different opinion. But especially when it comes to hypertonic saline, Canada says no, and the US says yes, it works. So that it shortens your stay. But Canada says no, it doesn't make any difference. Personally, when I've used hypertonic saline, when it became a thing that we're supposed to try this, I thought it made the kids worse because they did not like breathing in this hypertonic saline. They got upset and they looked like they were in worse distress. So I quickly stopped using it just because I felt that it was making the kids worse. But if you go to the US, they suggest that you use it. I think the pediatrician in the ward, when I asked that some are still using the hypertonic saline and others aren't. Chest physio. Uh, Short answer is no. Hasn't been shown to actually make any difference. The kids are the ones that get rid of the secretions out of their chest, and it's just going to take time for the body to heal, and chest physio doesn't help. That wonderful, cool, misty air also doesn't help. So that cool humidifier or putting cool mist to them isn't going to make any difference to their breathing. In hospital management. So again, it's just ongoing, it's just supportive care. We talk about concerns about respiratory, hydration, and parent understanding. So they realize that what we can do is only supportive care. So respiratory. Think of many concerns of if their respiratory rate is above 60, they may not be able to feed. They have increased chance of aspirating if it's above 60. It's kind of hard when you're breathing like literally every second and you got to try and feed in between those seconds. O2 saturations can go as low as 90% on these kids, and putting O2 on doesn't necessarily help them. So that's one of the guidelines that we have. Do not do continuous sats, especially while sleeping, because it's natural for everyone's sats to actually dip down while we're sleeping, and only helpful when you have quite severe distress, but it should never ever be used as a way of monitoring that the kid is getting worse. That is what clinical judgment is, going in and seeing the kid. Don't try and use the O2 sat monitor as a way to look for that. And again, if you're more likely to put them on continuous sat monitoring just because, oh, I'll just make sure that they're staying okay, they're much more likely to stay in hospital longer and they didn't need to be. So cardiorespiratory monitoring, especially for the kids less than 1 month of age, or again, the 48 weeks post-conception, or a previous history of apnea. And epinephrine, again, only if it helps. So this is our mission orders that we use at Health Sciences Center. But again, as it goes through all of it, it's really just pointing out the supportive care that the kids need. It's sort of like going in, washing in, do your vital signs, make sure their hydration is good. And epinephrine shouldn't be just scheduled. It should be only as needed. And they really, after going through the CPS guidelines, that'd be another project that these orders have to be revamped. So just to point out the utility of epinephrine. So a 9-month-old admitted for bronchiolitis. He's crying and in moderate to severe distress. He's on O2 by nasal prongs initially, but now he's up to a mask. Essentially, he's been getting epinephrine with a mask every hour. So they just aren't taking off. They just keep on giving him the epinephrine mask. So PIC was full, but they're quite concerned about this kid, that he's getting worse. And don't know, I wasn't on. I took over for this kid in the morning. So in desperation, the patient is sent back down to the emergency department. So you can imagine in the emergency department when the wards are full, the PICU is full with sick kids, the emergency room is probably also busy. So in the ER, again, rather busy. So the patient essentially was left asleep, cuddling with mom, and we didn't order any more epinephrine. So kid actually did much better. Patient was weaned off O2 down to nasal prongs and sent back to the ward in the morning. But it would just emphasize that by giving this kid the regular meds was actually the cause of him getting worse. So when we think about escalation of respiratory support, again, if most of the kids are going to stay on oxygen by nasal prongs and won't have to escalate any further. But some of those kids are going to need to increase the amount of oxygen they need. If that doesn't help them, then we go to high flow oxygen. And if that doesn't work, then we're on to CPAP and BiPAP. And then when that doesn't work, it's intubation. What they found with the high flow O2 is it didn't necessarily make that many, or it wasn't stopping them from necessarily escalating into intubation, but it seemed to help these kids and slow down the need for intubation. But it didn't change the numbers of the kids that were actually intubated. So hydration, important. Now, this is the one thing that I was very happy that I did this talk because I relooked at how I deal with hydration now for the bronchiolitic kids. So if you're going to start IV, it's either D5 normal saline or D5 Ringer's lactate. And there is concern that the sodium, especially when you're only giving IV, that the sodium can drop. So you have to watch this closely about every 6 hours if you're going to only give IV. But it's also shown that NG feeds as a bolus or continuous keeps these kids just as hydrated as putting an IV in them. And then you don't have to worry about trying to find an IV spot. So they're just as good. And more importantly, they don't get hungry if you use NG feeds, which these kids can be so upset because they're hungry. Education. Emphasize there's no medicine to make this go away. Wheeze will last a couple of weeks. And that's just the course. And again, think of the typical happy wheezer, driving the parents nuts, but the kid's doing fine. Cough will last at least 4 weeks or longer, potentially. Chest x-ray, again, does not diagnose bronchiolitis. And there's lots of handouts out there. There's actually with the electronic EPR, there's actually a patient handout that you can give from the EPR. Also, if you direct them toward the websites like the Canadian Pediatric Society and TREKK, just don't use Dr. Google. I'm sure there's lots of bad advice on Dr. Google. So discharge. Essentially, this is the discharge criteria list that they use at Health Sciences. But when it comes right down to it, your tachypnea is improved. You're not breathing above 60 anymore. Your work of breathing is improved. You're feeding by mouth, not by the NG. And O2 sats are 90 while awake. Again, emphasizing don't do continuous monitoring of O2 sats while you're sleeping, because most of these kids will land on O2 and they don't need to be. I'm sure I drove the nurses up in Thompson crazy because I would come in and keep telling them to take off the O2 sat monitor continuously because it's not helpful. And every day I would come in and yeah, the kid was back on O2. So let's think about asthma, which is always our concern about are we with this wheezing missing someone who's manic? Because I've just gone over that we can't give medications for bronchiolitis, but asthma, we need to give medications. So start thinking about it after 6 months, and again, more after 12 months. Think about it when that they're really they don't seem to be, their respiratory rate isn't that up, but they're really unhappy because they're having a hard time getting their breath in as well as getting it out. So they're not happy wheezers. also think about it when there's a prior episode of wheeze. So they've come in as their third episode, even under a year, and they're being said that it's bronchiolitis, but it's their third episode of wheezing. There might be something else going on. If they've had a prior response to salbutamol, so if someone gave them salbutamol in the past and it really helped them out, then try then. If there's a strong history of HP so that's eczema, asthma, hay fever, or anaphylaxis or allergies, or a family history, especially first, like either siblings or parents, think about it then. They tend to be asthma tends to be more wheezy, less crackly, and it's more think about it when it's not bronchiolitis season. So if you have someone come in the middle of the summer and they're wheezing away, that's a good time to think maybe it's actually asthma, not bronchiolitis. I just had a kid just recently transferred from the north in emergency, and reading through what they had given him, they had appropriately tried giving him epinephrine, and the kids seemed to do better with it. And the one thing that I remarked on was that the fact that they actually made the wheeze go away with the epinephrine. And so I'm like, you never make the wheeze go away with bronchiolitis. It's always there. You can get the work of breathing a bit better with bronchiolitis, but you don't make the wheeze go away. That doesn't happen. Um, and then I went in to talk to the family. He was 10 months old, so you would think still bronchiolitic versus asthma. But she said, no, this is the third time wheezing, and dad has really severe asthma. I'm sort of like, oh. So we totally changed tactic on this kid. Got him off the O2 by giving him the asthma care map. So give him a bunch of back-to-back Ventolin and start him on the steroids. And this kid looked great. So it didn't have to come in. So always have to think, even though he was still in the age range that we think bronchiolitis, that he was who actually was asthmatic. Still probably viral induced, but he was actually asthmatic. I remember going down to a conference uh, down in the States of the advanced airway, and the doc, who was obviously an adult emergency physician, not a pediatric emergency physician, they were talking about bronchiolitis and airway, and he described an 18-month-old. And he wanted to emphasize that we weren't supposed to be giving lots of masks and everything to the 18-month-old that was wheezing. And I looked at him and sort of like, 18 months old? Like, you have to think that it's not necessarily bronchiolitis. You got to broaden your differential, because an 18-month-old with bronchiolitis shouldn't be this sick looking. Um, and they actually, for the next people going through, they changed it to a 6-month-old, which was much more appropriate. So again, thinking of asthma and the more older kids, and looking at that atopic history. So here's my plug for immunizations. Why should we? So essentially, statistics wise, 2% of all infants are hospitalized with RSV in the first year of life. So essentially, you give birth to a child, there's a 1 in 50 chance that they will be admitted with bronchiolitis in their first year of life. That's not really great. It gets worse. So the farther north you live, the much more likely you are to be sick with a bronchiolitis. So it goes anywhere from 5 to 17%. So you're looking at close to like 1 in 5 chance, if you live in the north, that you'll be admitted with bronchiolitis. Those are not good odds. So immunizations, as you can tell with the fact that we can't treat this, we can only support them, that it's so important to prevent it in the first place. So what we have in Manitoba. So Synegus is, or I cannot pronounce the other name for it. You must give monthly. It's usually you give it for about 4 to 5 months. So they start tracking when we start getting RSV bronchiolitis. And then these kids who are on the plan start being brought in for their immunizations. And in Manitoba, we only give it to the ones at most risk. So this is the criteria for this year. So it is premature infants, so born less than 33 weeks, and they're less than 6 months at the start of RSV season. Children less than 24 months of age with chronic lung disease, children less than 24 that have hemodynamically significant heart disease, so cardiology usually refers them. Infants born between 33 to 35 if they're born after September 30th, and resides in the north. So those are going to be the most ones. You can also ask if you're concerned about increased risk, especially if you're living in the north. So small for gestational age, sibling, partially males, are at greater risk of having more difficulties. There's more than 5 individuals living in a household, which is majority of the north. 2 or more smokers in the household. Immediate family, all. I'm not sure what it means. Immediate family, all without eczema. This wasn't. I don't actually understand that one. And also concern on an individual basis, but not just the pediatrician, it's who is also involved with this kid has to apply for this. And the reason that they have these criteria, it is not cheap. It is quite expensive, unfortunately. But if you can save them from getting admitted to hospital and save a life, it money well worth spent.
Dr. Ridley, we have 2 questions, if we may pause for a moment.
Sure.
So first question, during the pandemic, NEBs were discouraged due to risks associated with it being an AGMP and concerns related to its effectiveness. For salbutamol, are you still preferring the puffer via aerochamber? Sorry.
Oh, nebulization versus the aero chamber. I guess for nebulization, I mean, we found out, I guess I'll go back anecdotally. There was a time where we were having difficulty that they didn't have the liquid Ventolin that we could put in the nebulization. So we really went into the MDIs a lot more for even the sicker kids, even the ones that were needing oxygen. And we found that they were getting better. So most of us reserve not using an MDI for the kids that just aren't breathing well. You're really worried that they're in severe distress. And that they aren't going to actually be able to breathe well enough for the MDI to get the Ventolin in. So we ended up going for really pushing on the MDI, and we found it was just effective. So we haven't really gone back from that. I mean, if we aren't so worried about nebulization with COVID, COVID is everywhere. We have no idea who's coming in with COVID anymore, so we aren't really worried about the aerosolization anymore. Again, when the kids get admitted to hospital, we isolate them. And most of us are all wearing our masks now when we go in and see the patients, so we aren't as vigilant about aerosolization of the viruses anymore. But some people are much more vigilant and they wear an N95 in. So I guess it's more of for the caregivers, it's more of a personal choice, but we aren't worried as much about the aerosolization anymore. And this is one thing. Karen, have you heard anything else?
Yeah, I haven't really heard anything else. Like you said, most of us wear masks and so forth. And the AGMP is still a concern. Try to wear, full PPE for intubation. It's less of a worry with that. And like Tracy said, we've been using MDIs with aero chambers for salbutamol since at least 2018, 2017, maybe earlier, and have just found so much better. I mean, the results are so much better, really, which made it nice when everyone else was scrambling to switch to MDIs. We already had a nice stock. There are kind of 2 exceptions that we still use masks for, and that is if a kiddo has an oxygen requirement that they can't tolerate off oxygen long enough to actually get the puffs. So we'll still use masks for that. And then the other is, a severe asthmatic doing continuous nebulization, and those kids will still do that. Otherwise, I think it's MDIs for 98% of our kids.
Yeah. I mean, we also are pretty good. with immunization, and now with the new stuff for adults, we can actually start getting immunized for RSV. So that might start happening as well, but it's not something. Gradually, we got less and less worried about the aerosolization of the viruses, except, of course, when we're intubating, then we're kind of up and close and personal to that airway. So, yeah, it's and even with COVID, I mean, I'm sure probably everyone in the departments had COVID, except those ones were incredibly careful with their N95s. But I didn't pick it up at work when I got my COVID. I picked it up from my kid. He brought it home from school. So, yeah, it's we don't really think of it the aerosolization until we're actually trying to intubate the kid. And we would try and keep the doors closed, but I mean, it's not just one single virus anymore. And that we realize that viruses are sent around quite easily, and just be cognizant of that. Try and keep doors closed when you're sick, because there's so many vulnerable people out there. So but in regards to MDI versus aerosolization, especially when it comes to use of salbutamol and asthmatics, we don't worry about it as much just because we so much use the MDIs. It's not really something that we think about.
And can I add just one more plug for the MDIs is one, it's a bit faster, but also your MDIs with aero chambers. So it's a really great opportunity. If someone comes in and you're giving, 15, 20, 30 puffs of salbutamol, you're also demonstrating how to use it. You're monitoring them, trying to use it, you're adjusting things. It's a great teaching opportunity because, as we know, sometimes kids come in, they say they've been taking their puffs, but they're not using it properly. So that's another huge pro for doing.
The only group I've seen that even are using nebulization, even for asthmatics as an outpatient, is when they've come from the States for whatever reason. And I can't imagine carrying around this machine to nebulize your Ventolin. The cost of it. That's what they recommended. It is so strange because I think it's pretty clear that recommendation is MDI is the superior device. Is there other questions I should answer?
One more. So, working rurally now, I had a bronchiolitis last winter and had advocated for eye epi treatment. And up to date stated to use saline nebs. So the MD I was working with was not on board until PEDS transport made the same suggestion. Is there another resource that I could reference in the future to support my suggestion?
Or let's just see here.
For the use of eye epi.
For epinephrine, after LFP as you do up to date. With for LFP versus, I'm not sure, but I understand the question. Was not on board until PEDS transport made the same. I find if you look at the CPS guidelines, they do have comments on the hypertonic saline. So I haven't seen any references for just a saline neb. Do they talk about hypertonic saline? With it, there isn't, again, there's not good recommendations for like cleaning up like using cold mist or anything like that. So no, I don't have any references where you're just using saline nebulizations for them.
Sorry, it's my question. So the doctor I was working with had looked on Up to Date, and Up to Date had recommended a hypertonic saline neb, and so he was not on board to
Oh,
give
okay.
an L-epi neb treatment a try because the recommendation per up to date was to do the hypertonic saline. And I was like, well, my experience in children's emerge is that we would do the L-epi for this kiddo. And so I was wondering if there was like kind of like a better reference that I could use in order to justify that in the future if I had a similar issue.
Okay, now I understand where it's coming from. So if you look at the AAP guidelines, so I went through the CPS guidelines as well as the American guidelines for treating bronchiolitis. And when it comes to epinephrine, the American guidelines are very against actually using epinephrine. They feel that you're biased when you're giving it. You think you're giving a med and you're helping them, but it's the bias of the person giving it that you're doing something to help them, and it doesn't help. So they are very against using epinephrine. They don't think it works at all. And they say actually hypertonic saline does work. The difficulty with all this evidence, it is just so equivocal that it's just maybe making a difference. So the US, the American Academy of Pediatrics decided that no, we think hypertonic saline makes a little bit of difference. So I'm pretty sure Up to Date is American based. So they're going to have that hypertonic saline works. And if you go by the CPS guidelines, they say, nope, there's not good enough evidence for it to work. It did come into vogue for a while that we were using hypertonic saline. That's why I used it in Emerge. But it has grown out of favor in the from the CPS guidelines, from the Canadian guidelines. So there is lots of evidence saying that it may make a difference, and there's a lot of evidence that says probably didn't make a difference. It's really difficult that way. Again, it comes down to supportive care for these kids, and don't do things that make them get worse. I'm going back to that case, the third case, where they wanted to get this kid feeling better, so they kept on giving him mass, and what he needed to be was left alone. So if you give the hypertonic saline, it makes him a little bit better, stops you from escalating care for him. Give it a try. Just don't expect it's going to take away all his symptoms. And if he's going to get worse, he's going to get worse. These things are not, these are all temporary measures that may help, and emphasis that even if it helped this one time for whatever reason, the next time you give it may not help the next time. So don't keep going at it thinking, oh, it helped once, let's keep going at it. You could actually be making the kid worse instead. So there's actually, you look at all the references, and 2 different societies have come up with exact opposite answers regarding to epinephrine and hypertonic saline.
I'll jump in just to say, as an American practicing now in Canada for 15 years, giving epi or any form of epi for bronchiolitis has never been a thing since I was a resident a long time ago. So I think it's a culture than anything else. And I think, I'll support what Tracy said, and what Daniel said in the chat as well, is some kids respond to that. Sometimes they don't. So it's hard to tell. At the end of the day, L-epi and bronchiolitis, it doesn't fix anything. It makes them feel better for a little bit. And you know what? If it works, if it makes them feel better for a little bit, that's worth it. But no one's under any illusion that giving L-epi shortens your hospital stay or anything like that. It's simply part of supportive care that works for some patients.
Right down to bronchiolitis is so frustrating. I mean, it's hard for the kids, obviously, because they're so sick, but it's so frustrating because we can't do anything. We can literally only support them, and we still want to make them better, and we've got nothing except support for them. It's tough, and it's very aggravating, and that's why they keep on going at the research the same, and somewhere along the lines of, oh, we're going to get this wonderful, make them better. When it comes down to it, the only thing you do is prevention. So I'm going over the for RSV. So Abrysvo, I don't know why they make all these names so hard to pronounce, but anyways, so this is given to pregnant people. I'm pretty sure you have to pay for it in Manitoba, but between 32 and 36 weeks, you can get RSV vaccination. So this is in the mom, the pregnant person, and reduction of RSV illness in young infants by 50%. So much so that if you give it correctly and the kid is born over after 2 weeks after you give it, they're probably immunized well enough that it decreases the illness in the infant by 50%. So if given less than 2 weeks, then it's still recommended if they would qualify for Synagis to still give it. But if they get it before the 2 weeks, then you probably do not have to give the Synagis. It probably wouldn't help more. Oops. Now, the one that other parts of the country have moved to, but not Manitoba. So this is my plug that if you know anyone who is part of the government, this is our plug to try and save these kids. It has been shown that for Beyfortus or Nirsevimab, okay, I'm going to stop that. You can give it once and it lasts for 1 season. So it lasts the 5 to 6 months. So you don't have to keep repeating it. A reduction of admission for RSV is decreased by 80%. That is big. And given the fact that, again, we only have supportive care, this literally is stopping RSV in its tracks. And it's suggested administration to all infants. Remember, it doesn't matter if you're sick or young. Again, obviously, if you have a concern that you're going to get sicker with bronchiolitis, it's much worse. But remember the original statistic, 2% of kids will be sick with the disease and be admitted for RSV. So a suggested administration to all infants younger than 8 months at the start of RSV season would decrease this illness by 80%. Well, that's huge. So this actually is a treatment. Unfortunately, you got to give it before you get RSV. So final words, likely the only thing that works is supportive care. Education and support the family is so important that they got to understand that we do not have a cure for this. The only thing we can do is support. I feel for those parents that come in because the kid is still feeding, the concern is not feeding right. It's hard, and they want their kid better. And it's so easy because there's so many fixes for so many illnesses, and we have nothing for this. The younger age and or significant past medical history can contribute to significant disease in the patient. And I always think of them for the potential need for escalation of care. So unfortunately, the more vulnerable, those are the ones that get the sickest. And just put a plug in for that new vectors thing. Concerned, give vectors a call and they'll get you in touch with the person that needs to help with the advice and for further management. So thank you.